Hi guys, welcome to our another lecture of the thoracic anatomy. So today we are going to talk about the anatomy of the lung. In our previous videos we spoke of the parietal pleura, the visceral pleura which takes part in the pleural cavity, right? So today we're going to talk about the lung. So as you know that the lungs are found in a space called your pleural cavity, surrounded by a fluid called the pleural fluid, and the lung is lined by visceral pleura, not parietal pleura, right? And then you have to take note that in children the lung is going to have a pinkish color, right? And then in adults the lung is going to have a dark gray color. This is due to exposure of um, external dust particles, smoke, and so forth. You understand? So our lung, we have two lungs, as we know. You have a right lung, you have a right lung and a left lung. The right lung and the left lung, they are all, they are not the same. They are different. As much as they carry the same function, gross anatomically, they are different. So you need to understand the difference between the right and the left lung. Right. So, general features of a lung. So a lung is conical in shape. You can see it is conical in shape. It has its apex that is convex, that will be entering the root of the neck. And then it has what's called a costal surface, right? That is convex, and a diaphragmatic surface that is concave, and a mediastinal surface that is concave. Very important. So the costal surface is convex, the diaphragmatic surface is concave, the mediastinal surface is concave. You understand? So the lung is going to have an anterior border. Okay, sorry. A lung is going to have an anterior border, a posterior border, right? So an anterior border of a lung, let me talk of the anterior border of the lung. So the anterior border of the lung is going to have different courses depending on which lung is it. So as for the right lung, the anterior border, it starts at the behind the level of the sternoclavicular joint, and then it descends downward up to the xiphoid process, and then it touches the diaphragmatic border or the inferior border of the lung. As for the left lung, the anterior border, it is sharp and they all overlap the heart. You have to understand that, right? It is sharp. It also starts behind the sternoclavicular joint. It descends. Then at the level of the fourth intercostal space or at the fourth costal cartilage, the anterior border is going to deviate laterally and go downward to meet at the level to meet the inferior border at the level of the xiphoid process. So it's going to form a notch that is called a cardiac notch. You can see a cardiac notch. So it turns at the fourth intercostal space to form a cardiac notch. Posteriorly, your lung has a posterior border that is thicker than your anterior border. Your posterior border of the lung, it comes from C7 to T10. C7 to T10, that's your posterior border. You understand? And then your inferior border now, that's the one that I want you to take note of it very much. The inferior border. Right. So there's an inferior border of the lung and there's an inferior border of the pleura, of the parietal pleura. They are different. So the inferior border of the lung, if you draw a curve like this, you're going to see that at the mid-clavicular line, the inferior border is going to be at the sixth rib. You understand? And then in the mid-axillary line, the inferior border of the lung is going to be at the eighth rib. You understand? And then posteriorly, the inferior border of the lung is going to be at the level of the at the level of the 10th thoracic vertebrae. So let's go again. The mid clavicular line, that is rib 6. The mid axillary line, that is what? Rib 8. And then the posterior border of the inferior, the posterior portion of the inferior border is going to be T10. So rib 6, mid clavicular line. Rib 8, mid axillary line. Then for the thoracic vertebrae, T10. So the orientation is the same if we are going to talk of the parietal pleura. So you'll be just adding 2 for the inferior border of the parietal pleura. So in the mid-axillary line, in the mid-clavicular line, the inferior border of the parietal layer is going to be at the rib number 8. 6 plus 2, 8. And then in the mid-axillary line, the inferior border of the parietal pleura is going to be at the level of rib 10, 8 plus 2. And then posteriorly, it's going to be along the level of T12. Very important. Right. So we are done with the borders. So let's now get to understand the difference between the right and the left lung. So we're going to start with the right lung. So this is your right lung. Your right lung is higher than your left lung. True. Because your right lung sits on the right dome of your liver. And the right dome of the liver is higher than the left dome of the liver. So the apex of the right lung is higher than the apex of the left lung. 2. The right lung is going to be divided into 3. The right lung has 3 lobes, while the left lung has only 2 lobes. So as you can see here, you can see that we have a superior or a cranial lobe, a middle, and inferior or caudal lobe. And they are all divided into these 3 lobes by 2 fissures. A horizontal fissure and an oblique fissure. So the horizontal fissure is the one that is unique. So let's go to the oblique fissure. So if you're going to draw a line from the root of the scapula going downward and anteriorly, right, meeting the 6th intercostal space, right, that will be your line for the oblique fissure. So your oblique fissure will run through the 6th intercostal space. 6th intercostal space, right? As for your horizontal fissure, so it will be a line in the 4th intercostal space that will meet the oblique fissure at the mid-axillary line within the 4th intercostal space. So the horizontal fissure will meet the oblique fissure at the mid-axillary line in the 4th intercostal space, thereby dividing the right lung into 3. 1, superior, middle, and inferior. Take note of this. As you are moving from superior to inferior, these are the relations of the lobes. The superior lobe, it is anterior and above to the mid lobe. And the mid lobe is anterior and above to the lower lobe, or the inferior lobe. You understand? Good. So here you can see this is now your mediastinal surface of your lung, and you can see that there is what you call a root of the lung. And remember, we said that the root of the lung is surrounded by a curve of pleura, which is made by the combination of your visceral and parietal pleura that will extend downward as your pulmonary ligament. Right. So in your right lung, you're going to have two bronchi, right? Two bronchi. So remember, your right bronchi is going to give a superior lobar branch before it enters the hilum. So therefore, you're going to have two bronchi entering the lungs, 1, 2, and then you're going to have your pulmonary artery and your pulmonary veins. Pulmonary artery will be entering, pulmonary veins, two of them will be leaving. You understand? Good. So you can actually see here, right? What are the structures that will be found on the hilum of the lung? Your bronchi, right? So this is your bronchi. This is another bronchi. So this is a superior bronchi going to your superior lobe, and then this one is your bronchi that will divide in within the lung to the one going to the mid and the one going to the inferior. You're also going to have some bronchial arteries. So bronchial arteries, as I'm going to talk about the blood supply to the lung, they are all going to come from the descending thoracic aorta, descending orothoracic aorta, going to supply the lung, right? Let's go to the left lung. So the left lung is going to have two lobes, this one and this one, and then it's going to be separated from the by the oblique fissure. So this is your oblique fissure. So your oblique fissure, same thing, posteriorly at the root of the spine, goes down and along the sixth intercostal space, touch the sixth rib and the sixth costal cartilages, right? Dividing into superior lobe and inferior lobe. The superior lobe is above and anterior to the inferior lobe. So which means that the inferior lobe is inferior and posterior. You understand? Take note of this. The superior lobe is a anterior border, and we said at the level of the fourth intercostal space, the anterior border will move laterally to create a region called a cardiac notch that will be accommodated by the heart. And then at the lower border of that cardiac notch, you have a what you call a lingula, an NB. A lingula, it's a part of the superior lobe, not part of the inferior lobe. You can see where it is. This is a lingula, part of the superior lobe, not part of the inferior lobe. Very typical MCQ question. You understand? Good. You can see even here, your lingula is part of the superior lobe, not inferior lobe. That's your lingula. Right? So you can actually see that your left lung, yes, is going to have some reflections or grooves of the following. So you're going to have the groove of your descending, you have the arc of the aorta and the descending aorta. Because remember, the ascending aorta, we have the ascending aorta, the arc of the aorta that will go towards the left and give the descending aorta, demarcated by the sternal ankle, lying along the sternal ankle. You remember? So the descending aorta is gonna form a groove on the left lung, not on the right lung. You understand? So you can actually see the descending aorta right here. So this is going to be your cardiac notch. This is going to be your lingula, which is a part of the superior lobe. This is going to be your diaphragmatic surface, right? And your left lung is smaller than the right lung. Your left lung is lower than the right lung because it is sitting on the left lobe of the liver that is smaller than the right lobe of the liver. Right. Let us go to the blood supply of the lung. Right. So our blood supply is separated into two. Take note of this. You're going to have what we call respiratory circulation and non-respiratory circulation. A respiratory circulation, it involves the blood that is going to the alveoli to undergo gaseous exchange. So this involves your pulmonary arteries, right? Your pulmonary arteries, they will form capillaries that will form the blood air barrier, and that's where gaseous exchange is going to take place. Carbon dioxide leaving, oxygen being absorbed into the blood, crossing the blood air barrier. Remember that, right? And take note of this. The, the pulmonary artery is going to be within what you call bronchopulmonary segments. Right. So, like we say that our lung is divided into, the right lung has 3 lobes, the left lung has 2 lobes, remember. And these lobes are further divided into what we call bronchopulmonary segments. And the bronchopulmonary segments are functional, anatomical, surgical units of the lung. They are very important because if they are they they are they act as units of the lungs that are separate to one another. So if there is a cancer of the lung that will be maybe in one part of the bronchopulmonary segment, it may not affect the other segment because they are functionally, anatomically, and surgically different. You understand? So you're going to have these bronchopulmonary segments different from one another. So in each bronchopulmonary segment, in the core of the bronchopulmonary segment, you're going to have segmental bronchi that are branches of your lobar bronchus, right? Remember? So the segmental bronchi, the segmental artery, which is the pulmonary artery or a branch of the pulmonary artery, they'll be lying in the core of your bronchopulmonary segment. But NB, the pulmonary vein, will be lying in the connective tissue between the bronchopulmonary segment. Is not within the bronchopulmonary segment. It is between. So it is also called intersegmental vein. Why? Because it lies in the connective tissue of your bronchopulmonary segment. So that forms your respiratory circulation. What about the non-respiratory circulation? Because remember, your lungs, they are also organs, and since they are organs, they also need blood. So they are not supplied by the pulmonary artery because the pulmonary artery carries deoxygenated blood coming from the right ventricle, right? But rather they're going to have a separate blood coming from what called bronchial arteries. Bronchial arteries. So for your non-respiratory circuit, you have your bronchial arteries. Bronchial arteries, these are branches that are coming from your descending aorta or your thoracic aorta, and then they are going to enter your hilar. You can see this is a bronchial artery. They'll be in pairs, two of them. And these are the bronchial arteries that will supply the lung, the connective tissue of the lung, the visceral pleural of the lung. I mentioned this when we were talking about the parietal cavity, when we were talking about the parietal and the visceral pleural. You understand now? So the bronchial arteries are the non-respiratory circuit which supplies the lung coming from the descending aorta or the thoracic aorta. As for the non-respiratory, as for the respiratory circulation, that's where we have the pulmonary artery that we said it is also called segmental artery. That will be together with the segmental bronchi within the bronchopulmonary segment, and the pulmonary vein that will be separate, or that will be between your bronchopulmonary segment, not within, in the connective tissue between. Right. Let's now go to the nervous supply. So at the hilar, you're also going to have your pulmonary plexus that will be coming from the vagus nerve and your sympathetic trunk. So remember, your vagus nerve always gives parasympathetic innervation. And parasympathetic innervation is responsible for three things in the lung. Take note, parasympathetic innervation coming from the vagus nerve. One, vasoconstriction. Sorry, let me start with the broncho. Bronchoconstriction, this is parasympathetic. Bronchoconstriction, vasodilation, secretomotor activity. That's parasympathetic. Sympathetic, we have a bronchodilation, vasoconstriction, inhibition of secretion. That's sympathetic. Coming from the pulmonary plexus. You understand now? Good. Done with the nervous supply. Now let us go to the lymph drainage of the lung. The lymph drainage of the lung. Let me see if I am able to look at diagram. Right, maybe I can use this one. So the lymph drainage of the lung is going to be divided into superficial and deep. The one that is superficial can also be called subpleural lymphatic tissue, right? So you're going to have the lymph of the superficial, from the superficial layer of the lung, that is your visceral layer, is going to drain into what's called bronchopulmonary lymph nodes. Bronchopulmonary lymph nodes at the hilar of the what? Of the lung. But as for your deep lymphatics, you're going to have pulmonary lymph nodes that will drain into your bronchopulmonary lymph nodes, and the bronchopulmonary lymph nodes will drain into your tracheobronchial lymph nodes, and the tracheobronchial lymph nodes, they are going to drain into your bronchomediastinal lymph nodes. That's where it gets exciting. The bronchomediastinal lymph nodes of the left drains into your thoracic duct. Remember this. And the bronchomediastinal lymph nodes of the right drains into the right lymphatic duct. We are going to talk about the lymphatic duct and the thoracic duct very soon. You understand? So that's everything about the nervous supply, blood supply, and the lymph drainage. Now let us go to the breathing movement of the lung. So I'm just going to summarize using this diagram right here. So you have to understand that we have three planes in which your thoracic cavity can expand. The one that I'm drawing, this is your vertical plane. That is called the vertical diameter. So the vertical diameter is increased by the contraction of the diaphragm. Remember, the suprapleural membrane does not contract, does not move. So it is the diaphragm that contracts, and when the diaphragm contracts, it expands towards the abdomen, and when it expands towards the abdomen, we are going to increase your thoracic cavity, thereby initiating inspiration. So your vertical diameter is due to the contraction of the diaphragm. You understand? We also have what you call anterior-posterior diameter. So the anterior-posterior diameter of your thoracic wall is going to be caused by the elevation of the upper ribs and the forward and upward movement of the sternum. This is done by the external intercostal muscles with the help of the superior, with the help of the serratus posterior superior muscles. Good. As for the transverse diameter is going to be caused by the raising of your lower ribs. Raising of your lower lateral ribs, raising of the lower lateral shaft portion of your lower ribs is going to increase your transverse diameter. So in terms of breathing, we have two phases of breathing. We have inspiration and expiration. Inspiration and expiration. Muscles, then inspiration is further divided into quiet inspiration and deep inspiration. Let's go to quiet inspiration. So in quiet inspiration, the major muscle for inspiration is the diaphragm. About 75% of inspiration is performed by your diaphragm with the help of your external intercostal muscles. That's quiet inspiration. So in quiet inspiration, that's where you have about 16 to 20 breaths per minute. 16 to 20 breaths per minute. Right? So it's very important to understand this. But in deep inspiration, you're now having the help of other muscles that take part in the elevation of your thorax or your thoracic cavity. We have the muscles that includes the elevatus costarum, the serratus posterior superior, the scalenus anterior and scalenus medius, right? As well as your pectoralis minor and pectoralis major, right? These are the muscles for forced deep inspiration. Take note of this. Quiet inspiration is passive, while forced deep inspiration is active. Active. Done. Let's now go to quiet expiration. So expiration is done by the recoiling of the lung. So quiet expiration is passive, and it is done or assisted by the internal intercostal artery, right? Whilst the lower rib is fixed by the quadratus lumborum muscle. The quadratus lumborum muscle it fixes the lower rib during expiration. So in deep expiration now, you have the assistance of the following muscles. The muscles of your abdominal wall, they contract, which is your external oblique muscle, your internal oblique muscle, your transversus abdominis muscle. They contract, increasing the intra-abdominal pressure, causing the diaphragm to move upwards to decrease the vertical diameter and decreasing the thoracic cavity, thereby promoting expiration. You understand? So muscles of expiration, you have your contraction of your abdominal muscles. And with the help of the serratus posterior inferior, those are the muscles of expiration. Take note of this as I close. Right. Inspiration is done, quiet inspiration is done when the first rib is fixed. Remember, the first rib and on its anterior superior border is going to be attached by the scalenus muscle, scalenus anterior and scalenus medius. So these muscles, they fix the first rib to prevent the thoracic ribs to get into the root of the neck. You understand? But as for the thoracic, as for the expiration, in quiet expiration, you have the the fixing of your 12th rib by the quadratus lumborum muscle. Quadratus lumborum muscle, which is muscle of the posterior portion of your abdominal wall. We're going to talk about it later. So I think I managed to touch everything that is important about the lungs. So you need to clearly understand the difference between the right lung and the left lung. So thank you so much, guys. Take care.